What I'm going to talk to you about this afternoon is how I basically reformed myself. I'm a doctor who's worked in patient safety my entire life, in particular in the area of infection prevention and control. And I work very differently now than I did 5 or 6 years ago. And what I thought I would do is take you through why I fundamentally changed how I approach patient safety issues. So here's my outline. In the beginning, I thought I knew all sorts of stuff. I was an expert. I had trained in quality. I had a master's degree and whatever, and I was all ready to go, and I was the expert. I then realized that me being the expert was largely irrelevant when I started working with frontline staff because they really didn't care. And so I went through a period of about 3 years trying to figure out what I was doing wrong. And then I'll give you some examples of essentially the new me, where I've realized that I was going about things all the wrong way in the beginning. So, as I said, I used to work, or I still do work in the area of infection prevention and control. And one of the things that I was challenged with was trying to improve hand hygiene compliance in our hospital. Now, I understand you had a talk about that earlier today, so I'll give you my experience with that. So when I started out in my role, I was the expert. I'm an infectious diseases physician. As I said, I've trained in essentially quality improvement. I know what to do. I've read the journals. I've got all the websites and all the guidelines. I made these posters that I thought were hilarious, and I would go around and hang them up in the hospital. We educated people's brains out. The concept being that if you didn't clean your hands, it's because you don't understand. So I'll educate you again, and when that fails, I'll educate you again. And eventually we'll make the education mandatory, and we'll actually take attendance to see if you've been educated, and that still didn't work. I was asked to send out nasty emails to people, "Dear Dr. So-and-so, it's been noted by your staff that you're not cleaning your hands. Could you please do so?" You can imagine how well those were taken by people. We would decide where the alcohol gel product would go. So we would walk around the wards and decide, well, according to the literature, it should go there, or it should go there. And we even created a program whereby if you were doing well, if you had good compliance, we would reward you with something. So you'll see the whole gist of this program is it's all about me. It's all about everything that I thought was important. Did I ask anybody else? No. Did I ever engage people to figure out what would work for them? No. Because why would I? I'm the expert. I've been trained. I know the literature, and I'm going to push this on you. And when it doesn't work, I'm going to get frustrated. We even did a thing whereby we had learned from other hospitals, they'd sometimes put up these various screensavers. So when you turn your hospital computer on, this is what you're faced with. So this one, they're showing examples of different organisms. Those are actually the real organisms. On this plate, we happen to have Staph aureus and strep, group A strep. And the point being that every time you booted up your computer, you'd be faced by this giant petri dish. And, other places had done that. It seemed to be successful. We thought that was a good idea. Boy, did it upset people. Nobody wanted to have their screensaver turned into a giant petri dish, apparently. And interestingly enough, I actually had one physician come up to me and tell me, "That screensaver is so annoying, I swear I'm never going to wash my hands again. I will purposefully not wash my hands between patients because you have pissed me off so much." Not quite the response I was looking for. I was looking for a little bit more enthusiasm and engagement. But all of these things that we were doing, we would make the posters and hang them up and come around a few weeks later and they'd be gone. We would give education sessions with loads of PowerPoint slides, and people would either sleep or say it was stupid, or somebody inevitably would put their hand up and say, "Excuse me, where's the randomized controlled trial that shows the hand washing is important?" All of these things that we were doing just met with resistance and, frankly, anger. Everything we were doing was creating the opposite response of what we wanted. Here's the best, though. This is my all-time favorite story. So at Cedars-Sinai in the States, although I sound like an American, I'm a Canadian, just to point that out, very different. At Cedars-Sinai in the States, they had a program that was run by the chief of medicine, which was to hand out Starbucks gift cards to doctors who clean their hands. And it worked very well there, apparently. The doctors got engaged and they thought it was fun, and it seemed to sort of contribute to their overall increase in hand hygiene compliance. So I read this story and I thought, hey, I'm a positive guy. Let's do something positive in our organization. We'll hand out Tim Hortons gift cards. Now, for those of you who aren't familiar with Canada, Tim Hortons is like a religion in Canada. It's right up there with hockey sticks. In fact, the two are actually co-branded together. You can't have a Tim Hortons ad on television without a hockey stick in there somewhere. It's unbelievable. It's part of our whole national identity. And yes, Tim Hortons was a hockey player, by the way, in case you were wondering. Anyway, we thought we would hand out gift certificates to Tim Hortons, and we'll give them to everybody, not just the doctors, because they're not so special. We'll give them to everybody, and it'll be a positive kind of campaign. So when I would do this, people would look at me like I was a bit odd, but they would, laugh and kind of appreciate it. But not everybody appreciated that program. One of our national newspapers, the Globe and Mail, wrote an article about this. Timbits are little tiny donuts given as a reward for hand washing. And basically, she wrote that Canada's largest research hospital will be handing out $2 gift certificates to help staff clean their hands. How do you think that went over in the national media? The Globe and Mail, the newspaper, actually had this editorial cartoon done, basically making fun of us. So that didn't go well. They also wrote an editorial about this, saying that it was a travesty that we would be using public health care dollars to pay for donuts. Now, we tried to write an op-ed back saying they can buy coffee with it, but they really didn't care. It was the donut thing had kind of stuck in everybody's head. We got some letters to the editor. Why is it so hard to get compliance on hand washing in Canadian hospitals? Hospitals in some European countries hardly have these bacterial outbreaks, and it seems like hand washing is just part of the very established routines that their staff follow. Is that really true? But anyway, this person thinks it is. You're all cleaning your hands in Europe. Who knew? Another person says, screw the Timbits, have a better idea. The reward for hand washing should be being able to keep your job. It goes on. The community did not like this. It was an absolute flop for us. But my personal favorite is the next letter to the editor, which was, I am outraged by the article in the Globe and Mail and the fact that people with public health degrees let the healthcare workers eat crap and sending the wrong message to the public. This goes on and on and on. How can you trust the doctor that approves of this? Which school did he get his degree from? Which medical school would say that eating donuts is a healthy choice? Shame on healthcare. It sounds like Donald Trump wrote this, for God's sakes. Anyway, the idea being what I thought was a great idea from another part of the world, right? That positive thing that you find that works somewhere else, that you bring into your culture and you try to do it, it didn't work in Canada at all. It was an absolute flop, even though it worked south of the border. So why did we do this? We did it because nothing else was working, and we were looking for something to try to get people to clean their hands. I was searching for what's the magic bullet to help me figure this out. I realized at that point it wasn't more education or screensavers or things like that. I was trying to get at behavior, albeit in the wrong way, but I was trying to get there. And I was lucky working in a hospital where my hospital leadership just kind of laughed all this off. They didn't think it was a big deal. I didn't get fired. They just basically said, keep trying, try something else. That did not work, by the way. Try something else and see where we can go with this. So I was at a meeting in Saskatchewan in January 2008, and yes, it was minus 35 degrees for those of you who haven't experienced that. That's when Celsius and Fahrenheit are actually the same on the scale. It's very bad news when you get into the minus 40 range. Very, very cold, and I went to a meeting. It was on infection control, and it was on the control of MRSA infections. And it was the usual stuff. You'd go poster after poster, person after person, talking about their education program, their surveillance program, their antimicrobial stewardship program. And then I walked into a room with a few people from Billings, Montana, of all places, which is a small little place in Montana. And they were talking about how they controlled MRSA by sitting in the room and really talking to people. And I was sort of intrigued by that. I'm like, well, what did you talk about? Well, whatever they wanted to talk about. And we would just sort of engage them and talk about MRSA and why it's bad, and if they had any ideas on how we might make MRSA better. And at this point, they've pulled all the chairs into a circle, and we're all sitting in a circle talking to each other. I'm like, what the heck is this? This is so weird. This is very uncomfortable for me. None of this is science-based. Who are the experts in the room? None of this makes sense. But I came away from it thinking, well, they actually did decrease their MRSA infections, and all the people in the room seemed happy. And I had never seen somebody working in infection control who was actually happy before. And so I thought, there's got to be something different about what they're doing, but I honestly couldn't describe what it was. We sort of described it like hugging a cloud. There was this different way of engaging people, but it was really too hard for me to understand. So I came away from that meeting not having a clue what they were talking about, but I was very intrigued that maybe these people were onto something, and there was a very different way of approaching these types of problems. So it got me thinking. Perhaps, even though I think I'm real smart and all, maybe I don't have the answers. Maybe I actually have no clue what motivates people. Maybe me standing up there and basically shaming you, telling you you're not cleaning your hands, surprisingly enough, does not motivate you. It sounds funny now, but at the time I thought that was the way to go. Perhaps we're focusing too much on education. Maybe people have good ideas, but I'm never listening to them. Maybe I never hear them. Maybe I just push my own ideas. And maybe I'm assuming that whatever ideas I have are going to spread throughout the organization. And then came the real cold truth. Maybe I'm part of the problem. Maybe the way that I'm engaging people or not engaging people is actually part of the problem, and that's why we're not getting anywhere. Maybe I need to fix myself and then go back again. So the group from Billings, Montana was talking about an approach called positive deviance, which is a social change approach which has been used all over the world for malnutrition, for all sorts of very difficult, wicked problems, complex challenges. And the concept is that in any group, there are some individuals who seem to outperform others. So what can we learn from that group, and how can we spread their ideas to the rest? The other thing I learned was about liberating structures, which are these very simple to use facilitation techniques. So you throw away the PowerPoint slides and you engage people in a very different way. So we started over a 3-year period to figure out how to use these concepts of positive deviance and liberating structures to engage people to bring about change. So we started using very different language. We started talking about generative solutions, the idea that you walk into a room with no idea what the solution is, but as you engage people, the solution starts to become evident. We started talking about being kind of almost making it up as we go along, figuring out our way forward as we work with people. We realized the importance of actual relationships. That it wasn't about the logic and the data, it was about who we're interacting with and how we're interacting with them. This essentially became what we call frontline ownership, which is the approach that we've used here in Ireland and in other places as well to deeply engage frontline staff to bring about changes to complex problems. So we went through 3 years of pain. This is a cactus. Shifting from talking to listening. So rather than walking into a room and telling people I have the answers, I would walk into a room and say, tell me what's going on. Help me understand what the problem is. I don't understand the problem. I don't do your job. I can't pretend that I know what's going on, so please tell me. Leading from behind. So as people came up with ideas, my job was not to take their idea and run with it, but to really empower them to lead and push the boulders out of the way for them so that they could be successful. Stop filtering their ideas. I was giving a talk on this in Rochester, New York a couple years ago, and the whole conference was on controlling C. difficile. And one of the people in the audience put up a hand during the question period, and they said, can you explain to me why we don't wear booties on our feet when patients have C. difficile? Because we're wearing all these gowns and gloves. the floor is presumably contaminated, and we're walking around with our shoes, and then we're tying our shoelaces, and isn't that a mechanism of spreading C. difficile? And the person who answered the question basically said, there's no evidence that your shoes are spreading this, booties are unnecessary, it's a waste of time. And you could see the look on the person's face just kind of fall. They were excited about controlling this, they had an idea, and their idea was killed in an open forum. And my response to that person was, I actually have no idea whether booties would control C. difficile, but I understand where your idea is coming from. Why don't you try it? Why don't you just try it? What's the harm? They're not suggesting doing brain biopsies on people. They're suggesting wearing booties. It's not a dangerous thing that they're suggesting. And I realized at that point, I've been filtering ideas my whole career. Bad idea, bad idea, bad idea. I like that idea. I'm going to take that idea. And all you do when you tell people they have a bad idea is you shut them down. I had to deal with role guilt, the idea that I was the leader and I was supposed to be in charge. But in fact, I had to give up on that and say my job as a leader is to push the obstacles out of the way, not to tell you what to do. And throughout all of this engagement, I was screaming for structure because this felt so foreign to me that I wouldn't preconceive a game plan and then roll it out, but rather the game plan would emerge as we talked to people. So we use this for hand washing. So for those of you who think getting healthcare workers to clean their hands is impossible, it's not. We just had to completely shift how we got them to clean their hands. And so you can see we went from 30% to well over 90% hand hygiene compliance. This is the usual WHO method for auditing hand hygiene compliance. None of that had changed throughout this period. And I also note that our MRSA rates have dropped about roughly 2/3 since we started this work. So here's a story. This is one of our internists. She stopped me in the elevator one day, talking about C. difficile actually, and said she had learned that some European countries have banned sleeves, and that all the physicians were out there wearing scrubs all the day. She asked me if I thought that was a good idea for controlling C. difficile. The old me would have said, there's no evidence that wearing scrubs is going to decrease C. difficile, right? There's no randomized controlled trial. The new me looked at her and said, that's a great idea, Katina. Why don't you try that? No harm can come from her wearing scrubs, and keep me posted. So she starts wearing scrubs to work. What happens? The nurses start challenging her and asking her, why are you wearing scrubs? You're not a surgeon. She explains she's afraid of spreading C. difficile. She wants to be able to wash her hands well. So she started wearing scrubs. She convinces the other doctors to wear scrubs as well. They're highly competitive. They get them monogrammed with their various team names on them. Now you've got 4 teams of internists competing with each other over who has the best hand hygiene compliance rate. These internists start training their residents to clean their hands. They actually get a group of master's students from University of Toronto to create a hand hygiene program specifically for internal medicine. All of this happened in a 1-second thing because I told her, yeah, why don't you try wearing scrubs? You don't know where these things are going to lead. This is part of the complexity of this, where a good idea, allow people to run with their ideas, no harm can come from that. Their hand hygiene compliance has actually increased dramatically. They're in the 90% as well. It's very hard to say what exactly that was attributed to, but people still talk about her changing to scrubs. The other fun thing about that story, though, is that it was working so well and people were so engaged, one of the other internists said to me, we should make wearing scrubs mandatory in the hospital. And I said, no, it's not about the scrubs. I don't think this has anything to do with scrubs per se. This has to do with her changing her behavior and her leading and other people seeing that. And the second that I tell people to wear scrubs, we'll be right back to where we were again. So it's a much more viral spread of ideas than telling people what to do. Just another quick example, there on the left-hand side is the stop sign. We stopped making signs. Our staff made signs if they wanted to make signs. The one on the left was made by one of the ward clerks, who it turns out in social network mapping was an absolute zealot about hand hygiene. She created that sign, and actually that sign is used in every one of our hospitals. It spread virally throughout the entire organization. I didn't make it, I didn't approve it, they just ran with it. The other one, the finger, is only on 2 of our cardiology floors, but that was created by one of our interventional cardiologists who thought the reason people weren't cleaning their hands was because the alcohol gel dispensers were beige and nobody could see them. The old me would have said, come on, you idiot, they're right there. Of course you can see them, right? The new me says, who am I to judge your work in your setting? If you say you can't see them, you can't see them. Do whatever you want to do. So those fingers spread throughout cardiology. This is our former surgeon-in-chief who was challenging our hand hygiene auditing data. The old me would have fought him on that and said our data are very robust, yada, yada. Instead, we invited him to audit with us, and he saw with his own eyes, he had social proof that nobody on his team were actually cleaning their hands, and he started changing his behavior based on that one interaction with the hand hygiene auditor. He needed to see it for himself. That story was repeated hundreds of times throughout our hospital, where we invited doctors to audit or other people to audit with us and see what we saw. So based on our experience there in Toronto, we started spreading this idea. And we've worked in multiple places in Canada and the US, and a little bit more faraway places such as New Zealand and most recently here in Ireland, where we've used that concept of frontline ownership to try to tackle difficult problems. And by the way, frontline ownership has also been used to develop antimicrobial stewardship programs where you're deeply engaging the people who you want to be part of a stewardship program and help them co-create what the program's going to look like. So these are data from New Zealand, where they were struggling with how to improve hand hygiene in their country. And one of the challenges they had, and this will probably resonate with you in Ireland, whatever came out of the capital city didn't necessarily go over so well elsewhere in the country. Where people would say, that's great that it works in Wellington or it works in Auckland, but here on the South Island, we don't do it that way. We're different. We want a different poster. We want everything different. And so they realized they couldn't have a one-size-fits-all hand hygiene program because it would only work in Auckland. And so what they did instead was create overarching simple rules. We all have to audit the same way, certain key things that had to be the same so that they could actually compare data. And then they allowed every program to create whatever made sense to them in their local environment by engaging the frontline staff. And so what they've been able to achieve here is pretty remarkable, where they've gone from around a 50% to an 80% hand hygiene compliance. None of this cost any money, by the way. This is just engaging people differently. In fact, they save money because they weren't building national posters and stuff that nobody was going to hang up. If you go to their website, Hand Hygiene New Zealand, they have a lovely story there about how they actually did this. This is our work in upstate New York, where we were working with 13 hospitals. We sort of joke, for those of you who remember Seinfeld, we called it a collaborative about nothing. There was no specific topic in the collaborative other than we taught them frontline ownership, and they could work on falls, pressure ulcers, surgical site infections, whatever they wanted. But the overarching similarity was we would teach them this approach. They had never, as you can see, they had a heck of a time trying to decrease falls, and then they started using our approach, and they started to see a sustained reduction in falls, again, for no money. This program wasn't about education or coming up with a new falls tool unless the frontline staff wanted it. It was about engaging the staff to figure out what solutions were going to work for them in their local environment. This is another collaborative we're part of out of Baltimore, which involves 40 hospitals working on sepsis prevention. The upper graph is the first cohort, where we were only somewhat involved. The second graph is the second cohort, where we were much more involved. And although I'm an infectious disease doctor, I wasn't there to talk to them about sepsis. I was there to help them with the gap between these are the national guidelines and what you're actually doing. There's usually a big gap. We all know what to do, we're just not able to do it. And so we worked with the frontline teams to coach them on when you're not able to get your blood cultures drawn within a certain amount of time, we'll work with you to figure out how to do that in your setting. And it may or may not be translatable to other sites. And so it was almost like guerrilla warfare. You're going basically hospital to hospital, ward to ward, team to team, engaging them to figure out what's going to work for them. Our most recent project was here in Ireland, in Kerry. And this was a different one in that it wasn't on patient safety. It was a project looking at engaging frontline teams to tackle problems that really meant something to them. And so we had groups working on waste management, on inter-team communication and culture, training and education. We also gave a number of workshops with various HSE staff, and some of you may have heard me speak at some of those and my colleague over the last year, where we trained people in frontline ownership, taught you some liberating structures, and helped you engage people in a different way. And the work had to be completed in 6 months, which is very fast for us. Normally this takes a year to a year and a half to really start to see change, but we sort of pulled out all the stops and pulled it off within 6 months. I was at a meeting in Copenhagen a couple weeks ago talking about positive deviance. So one of the things that we talked about was, how do you measure that this is working? In addition to your process and outcome measures, which we can all measure, we also look at 4 other things. So is there a change in equality? Are you taking a hierarchy and flattening it? Do I now feel comfortable talking to you even though you're in a different role? And we had people in Kerry saying they've met people that they've walked by for the last 10 years, but now they know who they are. They now feel comfortable speaking to a nurse or speaking to one of the doctors where they wouldn't have before. Do they feel happier? Are they happier in the work? And I think we have lots of evidence from that. Are they engaging in pro-social behaviors? In other words, are they essentially doing things for the good of the group? And if you go and look at the 2 posters from Kerry, they're quite fun to read. They've done a variety of things that have really changed their work environment for them. And are they more resilient? In other words, are they able to bend and then basically come back and also adapt with pressures and change? They brought in a number of things in a remarkably quick fashion. They were able to increase recycling, decrease food waste. They figured out some of their issues with mandatory training. They brought in the Hello, My Name Is campaign, which is a wonderful campaign, which has not made it to North America yet, although I'm trying to get it there. Staff engagement sections. They developed a choir. They have a koi pond. That's pretty cool. They've done all of these things through donations, etc., but they're all staff-driven. And the role of the administration was to push some of the boulders out of the way for them. Just some pictures from that group. It was really a wonderful experience to work there, to see the frontline staff take on these projects so quickly. Journey continues. This is an email I got last week. I'm working in British Columbia right now with a hospital that is involved in NSQIP, which you may know is the American Surgical Site Infection Program, where you benchmark against all these hospitals. And just to say, I've been working with them for a year, and the last sentence here, John says, in a nutshell, it's one of the best reports we've seen in a decade. They have gone from complete disengagement on surgical site infections to groups of literally tens, if not 100 people working on this now, because now they're actually empowered to do something about it rather than being talked at, they're being listened to. So I'll leave you with this slide. We don't fight the complexity, we really accept it. We get that it's going to be different everywhere we go, and we're only going to figure out our way forward by actually talking to people. We work with people who want to work with us. There's no right way to spread change. It's going to be different everywhere we go. When we were in Kerry, it was all about the canteen. That was the nerve center of the hospital. Other places we go to, they don't have canteens, so much for that idea. They're all different. We include everybody who's interested, so we don't just pick the usual suspects. We allow people time to spin their wheels. We create overarching simple rules, like in New Zealand, where we're all doing things differently, but we're bound together by these simple rules so that we can look at looking at our sharing our data, etc. Nothing about me without me is don't talk about me if I'm not in the room. We all have to actually open up communications. We encourage divergent thinking, so get the naysayers in the room. Get the people who think hand hygiene is stupid in the room and listen to them, rather than excluding them from the conversation. Last key point, ownership, not buy-in. Buy-in is what I did before. I create the entire program and then I bring it to you and I want you to buy into it. Ownership is, I know we need to get to there, but I don't know how to get there. So I'm going to co-create this thing with you. So by the time we're done, you're going to do this because you own it. It's yours. It's not mine, it's yours. We should really remove the word buy-in from our vocabulary in this field. Thank you very much.